Not all ovarian cysts are harmless fluid sacs. Some contain blood, tissue, or even mimic other structures. Ovarian cysts are fluid-filled or semi-solid structures in or around the ovary. They're common, but their appearance and meaning can vary widely. The most common are functional cysts, functional because they are part of the normal menstrual cycle rather than part of a disease process. They include follicular cysts or simple ovarian cysts and corpus luteum. Follicular cysts form when a follicle doesn't release an egg and ranges from 3 centimeters to 8 centimeters in size. Corpus luteum cysts are involved in ovulation and early pregnancy. It is simply the remnants of a ruptured dominant follicle after releasing an egg. It ranges from 2 centimeters to 5 centimeters in diameter, but disintegrates as it matures. The corpus luteum also produces estrogen and progesterone, maintaining optimum conditions for implantation if fertilization occurs. Often no symptoms, but can cause mild pelvic pain or delayed period and occasional rupture that results in sudden pain. They're usually harmless and self-resolving. Then we talk about PCOS. In polycystic ovarian syndrome, hormonal imbalance prevents normal ovulation, thus follicles accumulate without maturing, causing irregular or absent periods, acne, weight gain, excess hair growth, hirsutism, or even infertility. These are not true cysts, but arrested, immature follicles. We also have endometriomas, which are linked to endometriosis. This is when endometrial tissue grows outside the uterus, specifically the ovary, and bleeds cyclically, causing blood to collect in the ovary. This can cause chronic pelvic pain, painful periods, dysmenorrhea, pain during intercourse, and infertility. Repeated bleeding gives the classic chocolate cyst. Not everyone knows about ovarian dermoid cysts, also called mature cystic teratoma. These rise from germ cells that can differentiate into multiple tissue types and are often asymptomatic, but can cause abdominal fullness or mass. There's also risk of ovarian torsion if large. May contain hair, fat, teeth, or calcifications. When bleeding occurs into a functional cyst due to rupture of small blood vessels, it forms what we call hemorrhagic cyst, which can be accompanied with sudden pelvic pain or pain that may worsen with movement. Usually resolves within 8 weeks. We also have para-ovarian cysts. These arise from remnants of embryologic ducts near the ovary. Usually asymptomatic, may cause pressure if large, and are located next to, not inside, the ovary. Another cystic ovarian mass is the cystadenoma. This develops from ovarian surface epithelium, and there's 2 types, mucinous and serous cystadenomas. Mucinous cystadenomas are usually larger, multilocular, multiple cysts, and contain thick gelatinous material, while serous cystadenomas are smaller, frequently unilocular, single cyst, and filled with thin, watery fluid, often appearing bilateral. This typically presents as abdominal distension or pelvic pressure. They can grow very large, usually benign, but may require removal. Another cystic mass is the tubo-ovarian abscess, a severe pus-filled mass involving the fallopian tubes and ovaries. Often occurs when infection spreads, often from pelvic inflammatory disease, and usually presents with fever, severe pelvic pain, abnormal, heavy, or smelly vaginal discharge, pain during intercourse, nausea or vomiting, irregular vaginal bleeding, and tenderness on examination. It's a medical emergency requiring treatment. Lastly, hydrosalpinx. When a blocked fallopian tube is filled with fluid due to prior infection or inflammation. It is often asymptomatic and most commonly causes infertility. Can mimic an ovarian cyst on imaging.